And then that model, what it does is it's taking all of those inputs and finding those underlying relationships and patterns across that data to predict the patients that are at the highest risk of readmission.
Welcome to How AI Happens, a podcast where experts explain their work at the cutting edge of artificial intelligence. You'll hear from AI researchers, data scientists, and machine learning engineers as they get technical about the most exciting developments in their field and the challenges they're facing along the way. I'm your host, Rob Stevenson, and we're about to learn how AI happens. Today on How AI Happens, we're going to be looking at a specific instance of how AI can be used to measure, predict, and optimize challenging calculations regarding supply and demand. PointClickCare is a company applying predictive AI models to the tremendous challenge of optimizing the American healthcare system. PointClickCare has constructed a TensorFlow model to weigh a multitude of factors surrounding patient demographics as well as emergency department bandwidth in order to create a more effective and optimized hospital experience. To learn more, I caught up with Kelvin Wursten, who leads a team of data scientists for PointClickCare. Kelvin shared some of the considerations that inform this model, as well as where the responsibility for ensuring these technologies have relevant use cases truly lies.
I joined Collective Medical, a PointClickCare company, just over 3 years ago and lead our data science team here. And my role here is focused on supporting our hospital, health plan, and ACO customers. We build machine learning models to deliver insights in real time to treating providers and care coordinators. We also provide consulting analytics to show the impact on the healthcare cost utilization and healthcare outcomes through the use of our care coordination software. One of the main challenges and problems we are pointing our AI technologies at is the problem of healthcare overutilization. Throughout the United States, there is and has been for many decades just significant overutilization of healthcare services in the industry, which results in excess cost as well as poor patient outcomes. For example, nearly 1 in 5 patients are readmitted to the hospital following an inpatient stay. And there continues to be that significant overutilization of hospital emergency departments as well over those less costly and often more effective urgent care centers or primary care visits.
Unnecessary readmission, let's call it, is one example contributing to patient overutilization. It strikes me that this is a very delicate, complicated supply versus demand question. So I'm curious, just how does the model work? How does the model start to weigh all these factors and come out with an optimal solution?
In the model that we've built, we're taking the real-time data we get across hospitals across the country, and we're building in inputs for things like the patient demographics, chronic conditions, and patient visit history, as well as other inputs to put those into a deep neural network model. And then that model, what it does is it's taking all of those inputs and finding those underlying relationships and patterns across that data to predict the patients that are at the highest risk of readmission. And essentially, it's looking for patterns that the human brain may not be easily able to find. To give you an example, Rob, we actually had a client ask us about a specific patient and why their readmission risk was so low, because they looked at the patient and they said, oh, this patient has a stage 4 cancer diagnosis. And at face value, that looks like a patient that would be at high risk of going back to that hospital for a readmission. And when we dug into that specific patient, what we found was that that patient was actually discharged to hospice. And by definition, when you're going to hospice care, that means they're no longer trying to continue to treat you in a hospital setting, and they're trying to work on end-of-life care and palliative care to improve quality of life and avoid hospital stays going forward. And so the model was actually able to catch that and build that into the model and came up with a very low score for that patient, as opposed to the high score you might think of when you just see that stage 4 cancer diagnosis.
The downstream effects of solving patient overutilization are clearly huge, as is, I should point out, satisfactorily solving any complex supply versus demand calculation. I wanted to dig deeper into PointClickCare's TensorFlow model, what particular inputs the data science team deems predictive, and how they decided the TensorFlow approach was right for them.
Some of the features are those demographics, which include like age and gender, the chronic conditions and the diagnoses those patients have, and then looking at their visit history In addition, it would include things like number of historical addresses, where we're looking for, is there a pattern of housing insecurity, as that can be an indicator as well of risk for readmission. And so it's using all of those features to look for those patterns and identify those patients at highest risk of readmission that the model was powered on. When we built the model, we went through and tried 20 or so different models. We ended up using TensorFlow in our final model because it fit best with our current infrastructure, and it resulted in the best model that we had tried. We also looked at trying boosted tree models, some linear regression models, and XGBoost models as well. As we run the models, what we're looking at is the different metrics of success around each of the models. And specifically, what we focus on is typically the precision and sensitivity of the models. We look at the confusion matrices to see what are the true positives, true negatives, false positives, and false negatives. And then when we're talking with clients specifically, we talk about precision, which is of those that are predicted to readmit, what percent actually had a readmission, so that they can see if they don't have a model, they may be looking at a 10 to 20% readmission rate if they're doing outreach to every single patient, which means that 80 to 90% of their work is essentially not necessary. And then using a machine learning model, it can get them to a significantly higher precision, or of those that they outreach to, the percent that actually had a readmission. In the way we build our models, what we're looking for is how do we provide insights to our users that can fit directly into their workflow. You can build out a great model that has high accuracy and is very accurate, but if there's no workflow to put that model into, it's just going to sit and not get used. And so what we look for is we work with our clients to do discovery on what do their current workflows look like, and then design our models to fit into those workflows. We'll work with our product team to do that discovery, and then getting that user feedback so we can build the right models. As an example, I've seen in the past that we consider doing a model to predict the risk of dementia or Alzheimer's. And to make this meaningful, the challenge is you need a workflow that can fit into, because it's not like a care manager is going to call up the patient and say you're at risk of having Alzheimer's, because that's not a story they want to hear, and there may not be a good intervention that they can do to get them on a good care pathway. With a subsequent example being that internally, we've been looking at predicting patients that are at risk of significant overutilization of hospital emergency departments. So going to the ED instead of going to their primary care doctor. And those ED visits are significantly more costly than going to your primary care doctor. So initially we thought, hey, would be a great model that the emergency departments at hospitals would love to use. And upon doing some discovery with some of those EDs, many of them just didn't have the care management staff to actually utilize that model because they were too busy. And so what we've done is designed a model that can be used by the hospitals, but we're also then talking about how can we also give this to maybe a health plan case manager, or the case manager at an ACO, or to the primary care doctor who might have more time and bandwidth to do some follow-up with those patients to help get them to alternatives to using the EDs and getting them to visiting their primary care doctor instead of that high-cost ED.
From an AI product development standpoint, how much of this would you say falls on the practitioner, on the data scientist, on the ML engineer, for example, because they can do amazing things, right? But it all has to be steeped into a really usable real-world application that has to kind of fit in the hands of a consumer and be useful. So I'm curious, as you're directing your team, how much of these kind of questions are they servicing versus I don't know, man, I'm just going to get an R and do my work?
It's a critical component, because over time, the tools for developing machine learning models have gotten better and better, and just the technical skills that you need to build a model, those barriers have continued to decrease over time, and it becomes easier and easier on the technical side. And so as models become easier to build, the critical piece is then having the background and the healthcare knowledge and background to understand your users so that you build the model that will work for them instead of a model that just sits and doesn't get used. I continue to coach my team around, okay, what does the customer want? What do they say they want? What do they actually need? And how do you design for what they would actually use in real life? And then once we design those models, we send it out to our customers to use and get feedback and continue to iterate on those models to make sure it's meeting their needs and can really be used to improve those healthcare outcomes.
So let's say you have a massive data set, you have a team of brilliant data scientists, and they all understand the need to build with the user in mind. How do you make sure you're asking the right questions of your model and presenting the results in a manner that your user can, well, use?
One of the first problems is just getting that user adoption because, as you know, if you just say, here's a model and don't really explain it to them and just say, go use this risk model and it's a machine learning model, it doesn't immediately mean that they are going to adopt it and use it. And so what we've been doing a lot of work on is just putting in context setting for the models that we develop with our customers so that when we're talking to them, we can explain it to them in terms that they understand. So for example, like we typically don't use the term AUC or area under the curve to show the accuracy of our models because it's often overly technical and hard for them to understand how to fit into their workflow. And instead, we'll focus on things like the precision and recall and talk about, okay, if you have 100 patients you're going to outreach to for in a readmission model perspective, then with no model, you would expect that 10 to 20% of them would be readmitting. And so you're going to call 100 patients to get to that 10 or 20 that actually are at risk of readmitting. And then when you talk about the goals of using a model, it's to shrink the number of patients they actually have to outreach to. So maybe they only call 30 or 40, but of those 30 or 40, they're going to get half or more would actually readmit. And so they're much more efficient and effective in their outreach. And it's explaining that to them of, this is not just a machine learning model score, but it's actually going to improve how you use it in your workflow so that they can see the value of it themselves.
Yeah, it's such a tricky thing because, again, like in the example you shared earlier, where the output might be more interesting to a primary care doctor and, you know, someone who has a front office worker who can call someone and bring them in, as opposed to an emergency department who don't have the resources to be reaching out to all of their patients. There's sort of just like a business approach there that needs to be refined. And I'm wondering if AI's adoption, AI's widespread nature is somewhat hamstrung by the need to really figure out who it's the most useful to and put it in their hands, as opposed to the ability to generate the insight.
For sure. When I go back to that example on the emergency department and how they're too busy to do a lot of that follow-up care, it's also making sure that you have the tools, or that those clinicians have the tools to make it easy for them as well. And so they may say they're too busy to really utilize that model, but they might be thinking about using that in a complex intervention where they're doing follow-up after they've left the ED and they may not have time for that. But if you can get them to a pathway that's a lot easier, like for example, adding a note to their EHR about, hey, this patient is at risk of significant future emergency department use. We recommend they meet with their primary care doc. They mention their primary care doc's name. Here it is. And you can do some relatively easy things to help put them on a better path, even for those clinicians who may not have a lot of time. And so it's around, here's the model, and this will help you prioritize which patients to focus on. And then here's some simple workflows and workflow tasks that they can do that can really drive positive impacts.
Yeah, that makes sense. Going back to just sort of like the supply and demand of it all, how are you measuring the supply? Because you are sort of not inventing, but trying to figure out what is the optimal use for all these available hospital beds, the amount of individuals working, how long it takes to treat someone based on what they're admitted for. It just strikes me as a fantastically complicated calculation. And then there's two sides, right? Because that is different. The ability to deliver the care is different from the measuring the people seeking it, right? So what does that half of the model look like? How are you sort of building that and factoring in all these variables?
For sure. It's a challenging piece of the equation because if you look at like the US healthcare system, where historically it has been so much focused on fee-for-service, which is the more services you provide, the more you get paid. And as the system shifts to more value-based care, which is paying for value and the outcomes that you deliver, there's that natural tension between more services and more effective and better patient outcomes. And so as we develop the machine learning models that we're developing, we have to always be meeting each of our customers or our clients where they're at today, in that they're usually straddling that fee-for-service world and the value-based care world. And so how do we help them be effective in the different workflows they have today? So on the ED side, they actually can lose money if there are fewer ED visits at a hospital, even though that's often the least effective or the most costly place for those patients to receive care. But then it's around helping those hospital customers see that you may lose a little bit of money on the ED side, but that gives you more time to spend with those more complex patients where you can get paid more to offset some of those costs as well. And so it's about understanding their workflows enough so that you can give them the model that will continue to be financially viable, as well as improving patient outcomes. That continues to be one of the major challenges of just building any model in healthcare, of balancing the financial and economic incentives with the desires to improve patient outcomes.
Yeah, it's so fascinating. I mean, you get into just incentives here, right? And surely PointClickCare was founded with this belief that optimizing the healthcare experience and getting more care to more people is just an inherent good, right?
Yeah, I mean, it's getting the right care to the right patients that's critical, and reducing a lot of the inefficiencies in the healthcare space, because there are so many inefficiencies there.
How much would you say of AI tools is just like finding inefficiencies and then applying technology to make people more optimized and efficient? Like that seems like I'm just trying to, like, I'm seeing all these parallels, like the supply and demand of it all, the really understanding incentives in a workflow and just trying to alleviate it. This has implications, like if you solve the supply and demand sort of equation, this feels like it has implications for loads of industries.
I completely agree with that. And it's interesting because we'll often talk to some of our health plan customers about doing some of that post-discharge follow-up with a readmission model. And sometimes we'll get to a point where they'll say, well, we're just calling everyone and we want to keep calling everyone. And in that instance, it may not be very effective, but if they're not willing to change to do something that is more efficient and targeted, then there's not really a use case for a machine learning model. And so it's all around finding those customers who are looking for those ways to be more effective and efficient, and then delivering a model that will help them get there. And it can help reduce a lot of the inefficiencies throughout our whole healthcare system.
Yes, exactly. I'm curious to hear you wax a little poetic here, Kelvin. I want to know, surely you inhale lots of content about AI, and this problem would have to fascinate you for you to work on it such that you have. So I'm curious, maybe it's to do with healthcare and PointClickCare or just the industry writ large. What is it about this technology, the current state of it, the implications of it, the future of it, that really fascinates you and really has you excited?
If I take a step back and just think about where we are as an industry, like often in the AI space, the biggest challenge can be just getting access to the data. And I think with all of the limitations from HIPAA around the use of PHI data, it's a complex problem of just being able to use healthcare data to be able to develop models, and having enough of that healthcare data to develop those models. And I think that's one of the challenges, because even within any single given organization, they're not going to have all of the data, all of the medical data on their patient populations that they're treating. And so this information challenge around how do you get all of the data, and then once you have all of the data, it just opens up so much of what you can do in terms of improving healthcare outcomes and predicting different ways to improve workflows and care coordination and reducing that overutilization. And so it's just, I think as an industry, we're still stuck so much on just that data acquisition piece that we're just starting to unlock what we can do as an industry in the AI space and the models that can be built.
How AI Happens is brought to you by Sama. Sama provides accurate data for ambitious AI, specializing in image, video, and sensor data annotation and validation for machine learning algorithms in industries such as transportation, retail, e-commerce, media, medtech, robotics, and agriculture. For more information, head to sama.com.